There's so many misperceptions about palliative care, both amongst patients and their families and the public, and also health professionals. One of them, for example, is that palliative equals the last few days or the last few weeks of life or end of life. And as a result of that, people don't access improvement of quality of life, symptom management, earlier discussions, much earlier in the illness trajectory. If we keep thinking about it as being only end of life, many people are going to miss the opportunity to live much better in whatever time they have left. The other myth that is out there is that palliative care shortens life. In fact, quite recently I received an email from the wife of a patient who had died, and the email basically said, "For months and months I tried to get my husband connected with palliative care. And I was told by my team that is looking after us, my husband and I, that it would cause depression, increase depression, and take away hope and increase anxiety, in essence. And yet there's research to show that earlier activation of a palliative care approach, palliation of symptoms, improving quality of life, having these important discussions about end-of-life care, improves quality of life, reduces depression, reduces anxiety, and most staggering of all, people actually live longer because they're not now subjected to treatments that are burdensome and in fact may be shortening life. One of the most important things that needs to happen is that all healthcare providers need to take some responsibility of providing palliative care. It's unrealistic and unsustainable and also impossible to meet future needs if all of that rests on the shoulders of a small group of palliative care specialist teams. So we need to make sure that every physician, every nurse, every pharmacist, every health professional that has some contact with someone with a life-threatening or life-limiting illness has at least those important general basic core competencies to help patients. And most of the patients will benefit from those basic core competencies, having the discussions, having symptoms assessed and managed, having other symptoms, psychological symptoms addressed as well, fears, etc. If we don't build up that capacity, that what I call the generalist capacity or the primary level capacity, or we usually refer to it as a palliative approach, we're never going to meet the needs of the future. So we need to build up that, and we also need to ensure that there are enough specialist level providers to educate, to develop quality improvement programs, to do the research so as to improve the field, so that that research can guide better practices, the research can guide policy decisions around this issue. And until we have those levels in place, strong primary level, generalist, palliative care approach in place, supported by specialist level support, we're never going to meet the needs that are coming up in the future.